Hello, ladies and gentlemen. My name is Inowemem Opopo. I'm a second year resident at Florida Atlantic University, Internal Medicine Residency Program. Today, it's my pleasure to present a very interesting case to you all involving amoxicillin-induced liver injury with concomitant acute interstitial nephritis resulting in dialysis. I would love to initiate this conversation by presenting the case of a 75-year-old male with a recent tooth infection that was treated with amoxicillin 1 gram twice daily 4 days prior to his presentation. He came in with complaints of nausea and vomiting, right upper quadrant pain, as well as a blanchable rash on his back. His initial blood work was most significant for eosinophilia, as well as elevated LFTs and significantly elevated creatinine and BUN. There was an initial suspicion for drug-induced liver injury, for which his amoxicillin was therefore discontinued. Through the next couple of days, the patient continued to have progressive rise in his creatinine as well as worsening metabolic acidosis. He had a renal biopsy that confirmed acute interstitial nephritis and acute tubular necrosis with focal eosinophils. He was initiated on prednisone 1 mg per kilogram and subsequently initiated on hemodialysis given the worsened acidosis and actually had to be discharged on intermittent dialysis with close nephrology follow-up. At the time of discharge, his LFTs had returned back to normal. This case was of interest because drug-induced liver injury is something that has been seen and well documented with antibiotic use. Some of the most common antibiotics that have this adverse effect is augmentin. Amoxicillin monotherapy on its own, however, is not as commonly seen with drug-induced liver injury, and it actually tends to present differently as documented in the literature, which is more commonly a relatively younger patient as well as a more abrupt onset of presentation. Also, augmentin-related drug-induced liver injury has more of a cholestatic pattern as opposed to the mixed pattern of liver enzyme elevation that our patient presented with. This case is more so interesting because our patient also had his acute kidney injury due to the acute interstitial nephritis. Amoxicillin use has been seen in the past to cause acute interstitial nephritis, but it's typically a milder onset, more indolent onset, as opposed to the rapidly progressive renal failure that our patient presented with. And also, there's an extreme rarity of cases that have required renal replacement therapy, which our patient needed as well. Also, a study of the French pharmacovigilance database showed that a very minimal amount of amoxicillin-related adverse effects had this significant requirement of renal replacement therapy, and it was typically when it was an intravenous dose that was used as opposed to our patient's oral dose. Taking all of this together, we believe that clinicians should have a high suspicion for drug-induced liver injury and acute interstitial nephritis, or even acute kidney injury in general, when patients are on augmentin single therapy and they present with significantly elevated transaminases or rapidly progressing renal failure. The management for this is early discontinuation of the offending agent, and this patient should be managed in a hospital setting with close follow-up of their electrolytes with a BMP and creatinine as well as monitoring of their LFTs to monitor its progression. If there's non-improvement of this, we should consider renal replacement therapy, and nephrology should be consulted for their input as well. Thank you so much, and I hope you all learned something from this case.